Okay, the first really scary, no one wants to see this complication of labor that we're going to talk about is shoulder dystocia. Shoulder dystocia is one of the things that gives us the most anxiety because once the head is born, some of our other options for delivery are limited. So in shoulder dystocia, the head delivers, but the shoulders do not. Usually that has to do with rotation. The head delivers, but the rotation of the shoulders isn't quite right. And so instead of rotating and coming under the pubic bone one at a time, both shoulders are trying to come through the pelvis together and they get stuck. So what does that look like in delivery? Because we can't see the bones and the shoulders and all that. What we see is the head deliver. Normally in delivery, the head delivers and it rotates to one side or the other to face one leg. That's restitution. So if the head delivers and instead of rotating, it kind of pulls back against the perineum and stays in position, that's a sign that the shoulders may be trying to get stuck. Okay. So that's one of the things we look for. What are the risk factors? So a very large fetus obviously is a risk factor, but up to half of babies with shoulder dystocia are not actually macrosomic. So it is a risk factor, but it's not really predictive. It's not really strong enough to be predictive. Maternal diabetes is also a risk factor. Again, it's not super predictive, but if we have maternal diabetes and a macrosomic fetus, that is predictive of a very high likelihood of shoulder dystocia. So that risk is higher. Any patient who has had shoulder dystocia before is at risk for doing so again because it may have to do with the structure of the pelvis. We cannot really reliably predict or prevent shoulder dystocia. There are providers who will recommend C-section for any babies over, say, 9 pounds, and they kind of all, or maybe 9.5 pounds, they kind of all pick a place where they're comfortable. But there's no research to show any benefit to doing C-sections or C-section based just on fetal size. However, if the fetal size is estimated to be large and the mother is diabetic, there is some research showing benefit. That's the one case in which we can predict somewhat that there's a high likelihood or a higher likelihood. So what does this look like? During descent, as the baby's descending, it may start to slow down. And then, like I said, that turtle sign, the head delivers, and instead of rotating to the side to allow the shoulders to come out one at a time, it pulls back. Okay, that's called the turtle sign. The risk, the mother can be injured in the process of trying to get this fetus delivered. The mother can have postpartum hemorrhage because of all the things we're doing. The uterus is trying to push the baby out, the baby's not trying to come. So the reason this is such an urgent issue, and the reason we're doing things that may actually cause harm to the mother trying to deliver the fetus, is that venous return is restricted, but arterial flow is not. So the fetus is pumping blood to the head, but the venous return is constricted by the maternal tissues. So when we're sending blood into a space and not back out, we start to get some vascular congestion. We start to have increased pressure. Well, eventually we have so much pressure in the head that actually makes it impossible for more blood to go through in the arteries. If the veins can't drain, then the arteries run out of room to push blood, and so we cannot have, we have impeded arterial flow. At that point, we have a fetus that will have hypoxic brain damage or death if they're not delivered quickly. So in the process of trying to deliver this baby before we have brain damage, sometimes injuries happen to the mother. The fetus can also have, the infant can also have some other injuries. Brachial plexus injury is one of the most common when they're trying to get the baby out. The brachial plexus can be damaged and cause either temporary or permanent nerve damage to that arm. And that can involve sensation and movement, but more often movement. The phrenic nerve can also be injured, and this is more likely to be temporary. But if the phrenic nerve is injured, that affects diaphragmatic movement, and so it's going to affect the baby's ability to breathe independently. Management for shoulder dystocia is get that baby out. The very first thing we usually try is called the McRoberts maneuver because it's effective in a lot of cases. So in McRoberts, the patient needs, if they're sitting up, they need to be laid down somewhat. We move their legs. Typically, when we're having someone push, we have their legs bent and then kind of out to the side. We want to bend their legs up over the abdomen as much as possible. So not frog leg out to the side, up over the abdomen. Okay, that changes the shape of the pelvis a little bit. And then someone is putting, not fundal pressure, never fundal pressure. We're putting some pressure right over the pubic bone to try to help push that shoulder under. So the goal of this is to deliver the anterior shoulder first so the posterior shoulder can follow. So McRoberts would be the first. The Gasket Maneuver is one that some midwives used. It is used sometimes in hospitals, but it is a challenge because a lot of times in the hospital, mobility is more difficult due to monitors and IVs and epidurals. But if a patient is able to get up on their hands and knees, that also can be effective at changing the shape of the pelvis and allowing that the shoulders to deliver. There are some other maneuvers that providers use to try to deliver the baby. They try them in a specific order because they want to try what's most likely to be effective first, and then they start going through those other options. An episiotomy may be done to try to help make room for those maneuvers. We must avoid fundal pressure. So the nurse never is going to apply fundal pressure. We apply suprapubic pressure right above the pubic bone with McRoberts. The very last resort is to actually push the head back up into the uterus and do a C-section. That's called the Zavanelli maneuver, and it tends to have really terrible outcomes. After mother and baby are stable, they both need to be examined carefully for any injuries. The next one we're going to talk about is a prolapsed umbilical cord.